Let's jump straight into the clinical data. We are executing a high-level, strict clinical review of pulmonary hypertension today, specifically dissecting the hemodynamic matrix to distinguish between groups 1 through 4. Look, your ability to seamlessly integrate these precise parameters is exactly what separates a solid score from a perfect 280-plus performance. No basic introductions needed here. We are anchoring right on the gold standard right heart catheterization parameters.
So first things first, we absolutely have to establish the baseline pathology. You definitively prove pulmonary hypertension when a right heart catheterization reveals a mean pulmonary artery pressure, the MPAP, exceeding 20 millimeters of mercury at rest. Now, normal physiological pressure sits tightly between 8 and 20, right? So the second that MPAP breaches 20, boom, you have established the presence of pulmonary hypertension. But, and this is absolutely crucial, recognizing that elevated pressure is literally just step one. To actually manage your patient correctly, you must isolate exactly where that pressure is coming from.
And that brings us to the single most critical differentiator in this entire diagnostic algorithm, a strict threshold set at exactly 15 millimeters of mercury for the pulmonary capillary wedge pressure, or PCWP. You know this number. It serves as our most accurate surrogate for left atrial pressure. If the PCWP is 15 or less, it tells us the left heart is functioning perfectly. Therefore, the pathology has to lie strictly within the pulmonary vasculature or the lung parenchyma itself. Let's analyze the precapillary matrix by contrasting Group 1 directly with Group 4. Both of these present with an MPAP above 20 and a strictly normal PCWP of 15 or less. Group 1 is your classic pulmonary arterial hypertension. This is often idiopathic, familial, maybe you're looking at a BMPR2 mutation, or it's tied to a connective tissue disease. The destruction here occurs strictly within the pulmonary arteries themselves through intimal hyperplasia. Group 4, on the other hand, is driven by chronic thromboembolic disease. In this case, recurrent, unresolved pulmonary emboli have physically scarred and narrowed the vascular bed over time. But notice they share the exact same precapillary hemodynamic signature. The right ventricle is struggling against massive resistance, but the left heart remains completely shielded.
Now, because Group 4 is driven by chronic, organized clots, the diagnostic mandate is incredibly strict. It absolutely requires a VQ scan. If you find mismatched perfusion defects, the definitive life-saving therapy isn't medical, it is strictly surgical, a pulmonary thromboendarterectomy. Identifying this specific subset is paramount because this intervention is structurally corrective and, honestly, potentially curative for your patient.
Moving to our next distinct hemodynamic category, we really have to ask ourselves, what happens when the left heart fails? How does a failing left ventricle or a rigid left atrium shift the entire pressure dynamic backward? Well, if the left side of the heart can't pump efficiently, that pressure has to go somewhere, right? It inevitably backs up, first into the pulmonary veins and then subsequently right into the pulmonary arteries.
And this exact mechanism defines Group 2, which is actually the most common cause of pulmonary hypertension overall. It is driven entirely by left heart failure. That could be systolic dysfunction with a reduced EF, diastolic dysfunction, or even valvular disease like mitral stenosis. The hemodynamic signature here is undeniable. The RHC reveals an elevated MPAP above 20, but crucially, and this is the key, the PCWP is strictly greater than 15 millimeters of mercury. This absolutely proves that blood is pulling backward from the left side.
Now pay close attention here because this is where we see a highly lethal pharmacologic trap. Because the primary problem in Group 2 is left-sided fluid overload, pulmonary-specific vasodilators like bosentan or sildenafil are absolutely contraindicated. Think about the mechanism for a second. If you aggressively dilate those pulmonary arteries, you're going to massively increase the flow of blood right into the left atrium. That will completely flood the already failing left heart, precipitating flash pulmonary edema. The strict management for Group 2 relies on treating that left heart failure, utilizing agents like loop diuretics and ACE inhibitors to optimize left ventricular hemodynamics.
Okay, let's shift gears and dive into Group 3, the hypoxic constriction category. This is driven by chronic lung diseases. We're talking severe interstitial lung disease, COPD, or severe obstructive sleep apnea. Basically, chronic alveolar hypoxia triggers massive compensatory hypoxic pulmonary vasoconstriction. The lungs are structurally destroyed or chronically underventilated, forcing the right ventricle to pump against a heavily clamped down vascular bed. But just like we saw in Groups 1 and 4, the PCWP here remains completely normal, strictly at 15 or less.
The treatment mandate for Group 3 is strict. It demands an absolute focus on treating the underlying lung architecture. You do not reach for pulmonary vasodilators first here. Instead, strict adherence to therapies like CPAP for sleep apnea or long-term oxygen therapy for COPD is mandated. By directly correcting the hypoxemia, you reduce that compensatory hypoxic vasoconstriction and alleviate the dangerous strain on the right heart.
Well, let's isolate the clinical divergence on the physical exam for a moment to really differentiate precapillary from postcapillary states. Consider two different patients, both presenting with severe right heart failure, meaning they both have obvious jugular venous distension and major lower extremity edema. Now, if the patient has totally clear lungs and a PCW of 10, they have pure precapillary disease and strictly require a pulmonary vasodilator. Conversely, if a patient presents with right heart failure but also has bilateral basilar crackles, an S3 gallop, and a PCW of 22, they have postcapillary group 2 disease. This presentation strictly dictates aggressive loop diuresis to offload the fluid backing up from the left heart.
Let's actually put this matrix to the test with our master case assessment. Imagine the structural blueprint for a 65-year-old female presenting with severe exertional dyspnea, massive lower extremity edema, and a distinctly loud P2 on auscultation. You get an echocardiogram, and it estimates a frankly terrifying right ventricular systolic pressure of 60 millimeters of mercury. She is in florid right heart failure. So the absolute critical diagnostic question is, why?
The assessment aggressively tempts you with pulmonary-specific agents. The right heart catheterization data is right there. Her mean PAP is 45, which we know is severely elevated. Options A, B, and C, bosentan, epoprostenol, and sildenafil, are heavily seeded here to tempt you into directly treating the pulmonary hypertension. But these options are deliberately masking the lethal hemodynamic parameter sitting quietly in the data, a PCWP of 24.
We conclude with this ultimate assessment challenge. Will you blindly treat that high pulmonary pressure, or will you properly analyze the postcapillary wedge pressure to save your patient? With a PCWP of 24, this patient strictly defines Group 2 postcapillary pulmonary hypertension driven by left heart failure. Let's exhaustively break down those options. Option A, bosentan, an endothelin receptor antagonist, is absolutely contraindicated. It will precipitate flash pulmonary edema. Option B, epoprostenol, an IV prostanoid, is reserved for severe Group 1 PAH and will similarly flood her failing left ventricle. Option C, sildenafil, a PDE5 inhibitor, is also totally contraindicated in Group 2 disease. Option E, digoxin, is an inotrope that provides no mortality benefit and is absolutely not the immediate treatment for decompensated volume overload. Therefore, the correct answer must forcefully bypass the PAH drugs and strictly select option D, furosemide, a loop diuretic to immediately offload the left heart failure. Master the PCWP and you master the matrix. But consider this, if you misread a single pressure parameter on the wards, you could instantly flood your patient's lungs. So what other subtle hemodynamic clues are you currently missing in your daily practice? We'll see you in the next explainer.